provide the policy support and have been into policy advocacy for almost about 2 decades now. Today, I would like to draw the attention of our esteemed panel and also our audience who have joined in about a critical concern of organ donation. This, as we all know, is a life-saving practice, while advancing, still requires greater awareness and participation. Our webinar today would aim at highlighting the significance, addressing the gaps, and inspiring more individuals and attendees to consider becoming donors, embodying the true spirit of giving and humanity. With this, I'd like to request Dr. Mahajan, Dr. Harsh Mahajan, the chair of the Ficci Health Services Committee, and also the founder and chief radiologist of Mahajan Imaging and Labs, to give his welcome remarks and initiate the proceedings of the webinar today. Thank you, Dr. Mahajan, for joining in, and over to you, sir.
Thank you very much, Praveen. Good afternoon, everyone. A warm welcome to all the esteemed panelists and participants who have joined us today for this webinar on organ donation. At the outset, I wish to thank you for your interest and commitment to advancing public health and organ donation awareness across the country. Ficci has been at the very forefront of advocating for and supporting public health initiatives in India. Our mission has been to promote policies that enhance the well-being of our communities and foster a healthier nation. Today's webinar focuses on organ donation, a very noble act that embodies the essence of giving and can profoundly impact the lives of those in need. Organ donation is a critical area where increased awareness and understanding can lead to greater participation and save numerous lives. India, as we well know, has a severe shortage of organ donors. The organ donation rate in India is approximately 0.65 per million population, which is significantly lower compared to many other Western countries. As of 2023, it's estimated that over 500,000 people in India are awaiting organ transplants. Organ donation is not just a medical procedure. It's a life-affirming decision that can transform the lives of multiple individuals, the one who has the transplant, as well as entire families and extended families around. The main objective of today's webinar is to dispel misconceptions, present accurate information, and inspire more individuals to consider this act of generosity. We are privileged today to have Dr. Anil Kumar, the Director of National Organ and Tissue Transplant Organization, NATO, with us. Dr. Kumar's leadership and dedication to enhancing the organ donation and transplantation system in India have been pivotal in improving patient outcomes and saving lives. We were also to be joined by Dr. Aarti Vij, Chief of the AIMS Organ Retrieval and Banking Organization, or ORBO, who has given 25 years of her life to this noble cause. But she has been pulled out in an important meeting and will not be able to join us today. However, she did suggest that we initiate a working group at Ficci that could focus on policy recommendations and awareness generation on organ donation. We would be very, very happy to do so and take the entire crusade forward. I also thank Dr. Sanjeev for bringing on board all the specialists and experts for today's webinar. As we saw just now, there's a galaxy of people who are involved in various aspects of organ transplant, be it liver, be it kidney, be it heart, be it even the limbs. We have them all here today. As we proceed with today's discussions, I encourage all participants to actively engage, ask questions, and take away valuable knowledge and also enrich us with their own knowledge. Let us collectively work towards fostering a culture of generosity and empathy where organ donation becomes a widespread and accepted practice. And we at Ficci, and of course, across the entire healthcare fraternity, would implore you to join us in this crusade, which we hope to take in a formal manner following this webinar. Thank you all again very much. And over to you, Praveen, for taking the program forward. Thank you.
Thank you so much, Dr. Mahajan. I would also, request Dr. Sanjeev Singh, co-chair of Ficci Health Services Committee, and the medical director of Amrita Institute, Faridabad, and chief medical superintendent of AIMSRC Kochi to give his opening remarks and proceed with the moderation of the webinar. Today is, of course, a special day, and we wanted to thank Dr. Anil Kumar, who's joined and taken out time to be a part of this webinar. So over to you, Dr. Singh.
Right. Thank you, Praveenji, and thank you, Dr. Harsh. Dr. Harsh has been our chief mentor and has been the guiding light and has been doing some yeoman work. He is very well known in imaging, but then he has been doing phenomenal work in policy and advocacy and changing the healthcare practices in the country. And we really would like to congratulate Dr. Harsh for bringing all of us together at various platforms, and organ donation is just one of them. So thank you, Praveenji, for organizing this from the Ficci. And we know, as Dr. Harsh Mahajan just mentioned, that there is a large waiting list of 5 lakh patients. The organ donor 0.65 per million, which is fairly large, but with respect to the population which we have, we just don't meet the requirement. We have the expertise. Today we have got all of them together. There is a large chronic patient load, but then unfortunately we still lack on awareness, be it because of the logistics, be it because of the religious, and because of very many practices that we are unable to fulfill the requirement which is there, which provides us also for a good opportunity. But we all work under Human Organ Transplantation Act, and we are very happy that Dr. Anil Kumar, who is the director of the National Organ and Tissue Transplant Organization, who had been instrumental in streamlining the process of organ donation and transplantation in India, and had made significant strides towards increasing donor registration and improving overall transplantation system. It's to lay down policies, to have the state level, regional level, and the state level work within a framework, monitor them, maintain all the data, conduct those surveillances, and also maintain a registry. So we are very glad that Dr. Anil Kumar could join us today. And I would request Director Noto, Dr. Anil Kumar, to kindly comment and say a few words before we get started. And thank you very much for accepting the invitation and being here with us. Dr. Anil?
Can't hear you, Dr. Anil Kumar.
Dr. Kumar, you're on mute, I believe. We are unable to hear you, sir.
Can we check whether he is, though he's there on the panel?
Yes.
He is there, sir, but I believe
I'm calling him.
To talk earlier.
calling him.
Yeah. I think he'll rejoin.
Yeah, he'll probably be rejoining.
सर आप म्यूट पे अनम्यूट करिए हाँ अनम्यूट करिए आप हाँ जी नहीं you are still on mute.
So maybe you want to rejoin. Probably there's a sound issue.
हाँ, you please rejoin. हाँ, rejoin करिए आप. ठीक है. Sure, we'll wait.
So in the meantime, till Dr. Anil joins, we also have Dr. Colonel Avnish Seth, who is the head of Manipal Organ Sharing and Transplant, and he chairs the gastroenterology and hepatobiliary, who's going to share his insights on liver transplantation. And till Dr. Anil comes online, we also have Dr. Anant Kumar, who has done some remarkable work in the field of kidney transplantation. So chairs the Department of Urology and Kidney Transplant at Max Saket. We are fortunate to have Dr. Sundar, chair of Heart and Lung Transplant Surgery at Apollo, Chennai. And we have Dr. Mohit, who chairs the plastic and reconstructive surgery and has done hand transplantation from Amrita. And we were very glad to have Mohan Foundation, who has done some very, very phenomenal work in creating awareness and bringing all the people together and changing mindsets. So we are joined by Pallavi, who's the executive director, and we will also have one or two patients who will share their experiences. So is Dr. Anil, yeah, sir, if you can unmute yourself, and we would like to.
Am I audible now?
Yeah, you are, sir. Please go ahead, sir.
Okay. Thank you. Thanks to Ficci for organizing this webinar on organ donation, which is a great initiative. And thanks to the chair and the co-chair, Dr. Harsh Mahajan and Dr. Sanjeev Singh, for those kind words. I hope that this initiative by Ficci on this day will help in spreading the message widely among particularly the corporate hospital groups and other stakeholders which are associated with Ficci. Ficci has a very wide reach among the healthcare organizations, and we hope that this will be a very this will further the noble cause of organ donation and disseminate the information far and wide. So thank you so much for that. So I'll be talking about the topic which was given to me, National Action Plan and the Roadmap. Next slide, please. Yeah, next. So we estimate the requirements for, these are the new cases of kidney, liver and heart transplants that are added to the existing pool of the patients every year. This is the estimated number which is added every year, and cornea also 1 lakh cornea donations requirement every year. So last year we have, this is the number last year that we have done, that we have recorded in our registry. And in case of cornea, the number is as quoted by the Eye Bank Association of India, 28,000 only. And total transplants that we have done, 18,378, out of which 13,000 were 13,000 plus were kidneys, 4,491 liver, and 221 heart, lung around 200, pancreas 27, and small intestine 16 transplants. Next, please. If we compare our position in the world, we are at the third highest position in terms of total number of transplants in the world. This is 2022 data comparison of the top 10 countries of the world. And in the living donor transplants, we are at number 1. So living donor transplant is indicated by the red bar. You can see the red bar is the highest in case of India, while green bar indicates the deceased donor transplant proportion. And deceased donor transplant, you can see proportionately it was the lowest in compared to other countries. So the blue bar is the total number of transplants. So after US and China, we are at number 3 in terms of total number, and living donor we are at number 1. Next, please. We have been increasing our numbers of transplants over the year. If we look at the numbers, this is the total living donor transplants like over the years, we have increased. Next, please. Deceased donor number has also increased, but only around 3,000 transplants are being done from the organs that were obtained from the deceased donors. Next. This is the situation in the country. There are still red areas in the country where there has not been any deceased organ donation activity. Jammu Kashmir, Ladakh, entire northeast except Manipur and Assam, and then Jharkhand. These are the states where there has not been a single organ donation. That is the, in other states, the dark green areas are the areas where the activity has been very high and deceased organ donation, and it has also expanded. So next, please. One big issue that we have, like 891 hospitals which are doing organ donation and transplantation or tissue transplantation, and they are linked with the NOTO National Registry. And almost we estimate that now more around 95% of the hospitals are linked with NOTO. So this is a big network that we have. And but I just wish to inform you, around 15% of all these centers are only in government, 10 to 15% somewhere, depending upon the organ. Or
Dr. Anil, I think your signal is weak.
It's not audible.
No, go ahead, sir. We are able to hear.
Yeah. So my around 15% of these centers are in government sector, while 85% of the centers are in private sector. Next, please. So one of the aim with which the government is working is to reduce the demand for organ transplantation. So to reduce the demand for organ transplantation, government is also focusing on risk factors which cause organ damage. So these are various risk factors which cause different types of organ damage. Tobacco is a big risk factor. Obesity, alcohol, hypertension, physical inactivity. So that is very big risk factor. Nowadays we have non-alcoholic fatty liver disease. It has become an epidemic in our country. Around 40% of the patient population has some grade of fatty liver, mild to moderate level, and so this is leading to this. Dietary fats, like junk foods the people are eating, then uncontrollable, if you're not able to control your blood sugar, nutrition. So we are not like eating the healthy diets. So those risk factors, if we take care of them timely, then we will be able to prevent organ damage and organ failure. Next, please. So healthy eating, like very important, like we should select the items of variety of taste. We have like 6 tastes and 7 colors that we recommend, and eat right quantity. Avoid refined, processed, and preserved foods. Control intake of salt and sugar. Restrict fat to 15 to 20% of calories. So low saturated fats to be consumed. Avoid hydrogenated vanaspati type fats. Use variety of oils for cooking. Next. Then we have Pradhan Mantri National Dialysis Program, where if we provide quality dialysis up to the district level, it is also aimed at reducing the demand for transplant, where in certain patients this dialysis could also be equally good treatment, particularly in renal failure patients. Next, please. Next. Main challenges that I want to wish to highlight through this webinar, because hospitals are participating here. So there is a less number of, at the hospital level, we should look at that why we are not able to identify and certify our brainstem death, which are the potential donor cases, which are available almost in every ICU, and where the trauma and neuro cases are coming. So all the data that has to be now mandatorily provided to the national organization, to the national registry. Then donor maintenance, critical care, that has to be well understood and well learned. Infrastructure availability, particularly in government sector, the government is working on that. Potential recipients who can be benefited with transplant, they all should be offered this treatment. And we need to have a sustainable program in the hospital. Sometimes the hospital does just one heart transplant and then they just think that they have done their achievement, and they are not moving towards sustainable organ transplant program. Next, please. Our honorable Prime Minister has highlighted many times the importance of organ donation, and has stated that one organ donor can save 8 lives. Next, please. So we should promote like multi-organ donation. Like, it's not that my hospital is only having kidney transplant, I'll just ask for kidney. Like, we should counsel the family to agree for uh, every possible donation that is possible. And because the organ shortage is for every organ, so liver, kidneys, 2 lungs, pancreas, heart, and intestine. These are the vital 6 organs which have potential to save 8 to 9 lives. And next, besides that, we have tissue donation like cornea, skin. Skin can be donated even in at home, cornea as well as skin. And we now have 3 skin banks in the Delhi NCR region, in Delhi itself, basically. And so these services can be utilized. And skin is very important for treatment of the burns patients, particularly the which are deep burns. Next, please. We now have hand transplants also being done, and hands are being donated, and government has also now advocated for registry of the patients who require hand transplants. Next, please. We are also working to promote swab donation, where the swapping exchange of the incompatible donors is allowed between 2 pairs of organ donor and recipient, between the near relatives. Next. NATO is working to organize the entire system, the network that I talked about. So we have national organization, that is a National Organ and Tissue Transplant Organization. We have 5 regional organizations and 21 state level organizations as of now, and they link with 891 hospitals. Next. So whenever a patient requires a organ from a organ donor, that registration is done by the particular treating hospital. Every treating hospital has a login ID and password. They will enter the patient detail, and then the name of the patient will be added in the waiting list. So once the donor becomes available, the information will go to the particular that is the state level networking organization, and as per the allocation policy, allocate. Yeah, as you all know that these donated organs, they have to be transplanted very quickly. They cannot be stored. So only the tissues can be stored, but donated organs, they have to be transplanted. There are timelines within which they have to be transplanted. Maximum is for kidney 24 hours, and heart is within 4 hours, 4 to maximum 6 hours. So this transplant, which is done, this has to be organized because there are disparities in the infrastructure. Even in Delhi, many times nobody is there to take the heart, donated heart, and the heart is then transported to the other institutions in south or in western region for transplant. So this kind of a situation many times arises, particularly for heart and lung transplant, where we have to transport these organs. So we have a uniform now organ transport policy, which has been devised by Government of India, and SOPs, standard operative procedures for the organ transport are now there, and there is a nodal officer at every airport, and there are green corridors created on the roads. So with the help of the police and the various ministries involved, the things have been now smoothened out, SOPs have been laid out and have been recently released, and there is a nodal officer at every airport to facilitate transport within the minimum time so that we are able to transport without losing the functionality of the organ. Next, please. Government also provides various financial support to the states for improving infrastructure, like setting up of the organization, these ROTO and SOTO, retrieval centers, donor centers, basically transplant centers, and also upgradation and tissue banks also. So these grants are provided to the states as per the proposals received. Next, please. Besides, we under the program, we provide a grant of 10,000 rupees per month to the BPL post-transplant patients for their immunosuppressive treatment. And dignified funeral of the donor, government as a mark of respects also provide 10,000 rupees per deceased donor for dignified funeral. So these grants should be availed, and we have given instructions that now 2 representatives of SOTO will go to pay their respect at the time of donation at the site of donation. So then we also provide a grant of maintenance of deceased donor at the rate of rupees 1 lakh per donation, where if one donated organ is coming to a government facility, that is the rider, and for awareness as well as capacity building, the grants are provided. Next, please. For poor patients under the Rashtriya Arogya Nidhi, 15 lakh up to 15 lakh rupees, the grants are provided for kidney, liver, heart, as well as lung transplantation. Next, please. Under Pradhan Mantri Jan Arogya Yojana, which you know is a insurance scheme for, and there the renal transplant is also covered, so that people can avail, which are beneficiaries, they can avail this treatment under this scheme from the empaneled hospitals. Next, please. Next, yeah. We like now government has issued a circular that post-mortem for organ donation should be taken on priority and be conducted even after sunset if adequate infrastructure is available. So it should not be delayed. The handing over of the body should not be delayed. Next, please. Next. I'll just previous slide. So 42 days of special casual leave to the central government employees for organ donation has been sanctioned. Next. We are now advocating for audit of the brainstem death cases. Every hospital has been asked to identify a nodal officer, and the nodal officer should monitor in their ICUs whether how many patients of brainstem death could be there, and like particularly which are trauma victims, or they are the cases of intracranial hemorrhage. So those cases, they should be monitored, like which are having GCS less than 5, like they could be potential donors, and somebody should try to check whether they are brain dead or not. And if then get them certified, get the family member consult. So this kind of a monitoring and should be done. It's not that we are having these patients, but we are not identifying, we are not counseling them, we are not informing them. Awareness is increasing, but somebody in the hospital has to take initiative and ask for organ donation. Next, please. Next, please. Next. Yeah. Such kind of boards we have, advocate to be put up outside the ICU, where it is written that doctor or transplant coordinator on duty are required by law to request for organ donation. So, and the relative should cooperate in this noble cause. So this kind of a thing is, such boards are now being put up almost in every hospital. Next, please. Every donor and recipient will be tracked by Noto, because so every detail has to be entered into the Noto website, and a unique Noto ID will be generated. So any patient in the country can go to any state for receiving an organ from a deceased donor or registering for that, and there is no fee for registration, and no age limit for registration, and no domicile requirement. So one person can travel to any part of the country, but only from one hospital he will be registered, and his unique Noto ID will be generated, and he has the option to change the hospital, and his seniority in the waiting list will continue the same as from the first time wherever he has registered from. His ID will remain same. So this is the way, like we are trying to track each and every donor and recipient. Next, please. Yeah. So, so as I've said that even the transplant hospitals or the corporate hospitals, they must have promote disease donation. They must have a system in their hospital where they request for organ donation from the family members. Such kind of boards are put up. They identify these donors which are there in their ICUs. Next, please. You can even have dedicated beds for maintaining the patients who are potential donors. Then this is for the state government, that advisory committees are have now been they have been asked to form our advisory committee and make them functional. Next, please. I'll just take 5 more minutes. Foreigners transplant, because you must have heard certain media news through, like, in last 1 year, where people they where foreigners, they come to India for transplant. It's a good number, and government promotes that under the Health in India initiative, basically Heal in India initiative, and they are welcome to come, but they need to follow the law of the land when they are coming here. So it is mandatory that our Transplant Act has to be followed. So this information about the rules of the transplant has been given to the to all the embassies which are located in India, and also through our when they are seeking the visa from Indian embassies, so all Indian missions are also displaying these rules of transplant now, either on their website or they are displayed in their offices, so that they are well aware that of the rules of transplant before they come for transplant here. Next, please. We also, coordinate with trauma center. We should be able to, like in the road traffic accident, if there is a severe accident, the brain is crushed. So we need to see, like if we are not able, we should bring them quickly to the nearest hospital. And if we are not able to salvage the life, then try to at least counsel the family that this is the opportunity for donation. This person is brain dead, and between the time till the time the heart is going to stop, this window period between the brain dead time and the stoppage of the heart is the opportunity for organ donation. That opportunity has to be explained very well to the family, and they need to be, educated about it and counseled about it. They may refuse, but our duty as a hospital doctor is to educate the family very well about it. Next, please. And we need to tell that, next, please, that it is not just one person is going, it is that his organs are going to survive through many bodies. And it will be help in a way, he will be also be saving so many lives. So we have a 24/7 call center, which is 1800 114 770. So for any information or organ donation, or if somebody wants a donation to be done at home, like cornea or skin, then the intimation has to come, which is possible only within 6 hours after the death. And so they can call, and our team will coordinate to arrange for organ to be these tissues to be retrieved from the home. So wherever, this is a all India national helpline, and we coordinate for the entire country. Next, please. Various awareness messages are there on our website. They can be seen. Next, please. We have increased our awareness activities, outreach to till the village level last year, like we had gone through various initiatives of the ministry. Next, please. Various slogans like Ek Khamoshi Anek Muskan, Aao Kare Angdan Jeevan Dan, donate organs, save lives, Punya Mile Sab Daan Se, Punya और जीवन दोनों मिले अंगदान से. Next, please. This is a small video which we are promoting. Yeah, just hold. Basically, this is to we are promoting, like when we are alive and kicking. So when we can decide for ourselves. So why not to register as and sign up as a organ donor? This is a website, noto.abdm.gov.in, which can be accessed even through this QR code which is displayed here. And if you go to this website, and through your Aadhaar number, you will get an OTP. Then the form opens. So you just enter the form, and then this donor card is generated within just 1.5 minutes. So it is very simple. The registration process is very simple. This was launched last year on 17 September. It is less than a year, and around 1.8 lakh people have already signed up as an organ donor till now. Today, the Big FM has also launched a campaign, Bano India Ke Angdata. So we are also supporting that. Just play this video. It is just 1 minute. So go to the website. Yeah, please. Click register for pledge. Only 5 steps. And download the certificate. It's the website homepage here. You enter your Aadhaar number, verify, and the form opens. And enter personal details, which organs and tissues you want to donate. Yeah. Enter emergency contact details, and other members to be notified. So this is the certificate generated, and in the beautiful national tricolor, you will get your certificate, and your name is entered into the national registry. Next, please. Next slide. So basically, we should understand that death is an inevitable truth, and nobody is there to live forever. We all have to die here. But but organs cannot be taken to the heaven. So why burn or bury? why not to donate our organs if they can, when we have the option to donate and save lives. Next, please. So organs you cannot take to the heaven, and they are needed here, so they need to be donated. Next, please. So donate organs, save lives. Ang Dan, Jivan Dan. Next. We are working towards self-sufficiency in organ transplantation through various, already elaborated, next, please. So we are looking for one nation, one allocation policy, one registry, one portal, and digitized computer-based, fully computer-based allocation of the donated organs. Donated organ, we consider it as a national resource, and not even one donated organ should be wasted. Next. Thank you so much. Thank you.
Right, sir. Thank you so much. That was fantastic. You took us through the journey and the whole framework of Noto and Jivandan, Angdan, and do not take them to heaven. Your point is bang on. And the whole idea of preparing a one nation, one policy, one portal, one registry, and going digital, it just gives a remarkable reassurance to all of us that under your leadership, the implementation and promoting that awareness program and facilitation of equitable distribution. And you mentioned about including foreigners. I'm sure there will be lots and lots of good work which would happen. And thank you so much for sharing, though it was a very, very lucid presentation. And I also learned quite a bit during this meeting. I would request you to just stay for some more time. We'll go through some of the presentations with our chief surgeons who have done some remarkable work. And first of all, I would like to call upon Dr. Avnish Seth. Sir is an alumni of AFMC Pune, and he completed his medicine from Pune University, DM gastroenterology from PGI Chandigarh, and a fellowship in liver transplantation from Birmingham. He is a decorated officer, recipient of a Vishisht Seva Medal, and has established first successful liver transplantation in government hospital in RNR. So that is a real success. Over to you. He chairs the GI and HPB program at Manipal. Thank you so much for accepting our invitation. Over to you, sir.
Thank you, Sanjeev. Hope you hear me well.
Yeah, absolutely. Loud and clear, sir.
Can I have the next slide, please? I'll try to be brief and talk about where we are in liver transplant. So, as you can see here, liver transplant started sometime in the late 90s, and by 2013, we were doing close to 900. And that figure has now gone up to more than 4,000. And very importantly, the red bar, which is the disease donor program, has crossed 800. And almost 1/5 of our liver transplants we are now doing with disease donor. So a lot has been achieved, as Dr. Anil was talking about, but we still meet only about 10% of the projected requirement for livers. So there is work in progress in that field. Next one. The good thing is that we have more than 200 centers performing liver transplant in the country, and we have started publishing. So more than 300 publications in the last 5 years. So there's lots to share, and we have the expertise to now tell the world how good we are. Next one. What are we transplanting for? We have moved from hepatitis B and hepatitis C to metabolic syndrome. And Dr. Anil very correctly pointed out that prevention is very important in this whole field so that people don't need transplants. And if you see now that the top two indications in our country for liver transplant are, we used to call it fatty liver or NASH earlier, now we call it metabolic dysfunction associated liver disease. And the second is alcohol. So both are extremely preventable. Next one. So what is changing in liver transplant in India? We are getting better and better. We are able to transplant older recipients We are able to take up people who are nutritionally very poor and frail. We are transplanting patients who are 150 kg if required for fatty liver disease, more sick patients, more patients with acute and chronic liver failure, patients with liver cancers, hepatocellular carcinoma, beyond the conventional criteria also are doing pretty well in some transplants in India. And now we are moving towards the non-HCC liver tumors. We are transplanting for neuroendocrine liver tumors, cholangiocarcinomas, metastasis from colon, of course, under very strict and stringent criteria that we follow. Our patients are very sick now. We are able to transplant patients with dual liver and kidney transplant, but we continue to struggle with resistant infections, fungal infections, and tuberculosis. Next one. How are we on outcomes? So we now have an Indian liver transplant registry, which is a fantastic thing, started by the Liver Transplant Society of India. And from 2019, 7,800 patients' data and outcomes is registered there. Unfortunately, out of the 200 plus hospitals, only 35 hospitals are contributing so far. And we are hoping that others will also join in. But if you see here on the right side, the 1 year, 5 year, and 10-year survival after liver transplant matches the global standards of 90, 80, and 75%. So our outcomes are getting better and better over the last decade or two. And we are right up there with the rest of the world. Next slide. But what are the issues with liver transplant? 80% are done in the private sector. We need the public sector to step up. 80% are from living donor. We need more from donation after death. 70% recipients are male, so some gender bias is definitely happening here. And look at that, 70% transplants are done by 5 states. So the rest of the country needs to pick up. And if you see here, Delhi does the maximum number of liver transplants in the country, but we need this to come up in every part of the country. 10% of all our organ transplant recipients are foreigners. So even though we talk about 4,000 odd liver transplants, for the common Indian man, this still remains a dream rather than a reality. Next slide. With living donor liver transplant, we have achieved excellence in India. There is no waiting period required because we are not waiting for someone to have a disease donation, so it happens quickly. Donor safety is much improved now. We have very nice softwares. We do good volumetry, and the donor liver surgery is done laparoscopically with robotics. So there's much more better surgical skills. And look at what all we are pushing now. 2 donors can be used to give to 1 recipient, advanced liver cancers, alcoholic liver disease, ABO incompatible, and even swaps that we spoke about earlier. So this is all has been achieved well and truly in India. Next one. But my concern is on the other side of the coin with living donor liver transplant. Donor mortality and morbidity still remains concern. It's a major surgery for the donor. Gender bias in donors, if about 70% of our donors are females, there's definitely a possibility of subtle coercion within the family. So this remains to be addressed. Unrelated living donors and scams keep popping up. So the only answer to this is to have large amount of disease donation. If a liver doesn't work after the living organ donation, we don't have a backup liver. And of course, in an emergency situation, when we transplant in acute liver failures within a day or two, what is the lack of transparency? That is what should be worried about in these situations. How much does the family know about the benefits and risks? And there's a recent trend in 3 states of allowing children below 18 to become living liver donors. And I personally feel this needs to be curbed. Next one. About disease donor, you can see the dark part of the liver, the dark part of the map in India. That is where most of the donations are happening, and that is where most of the disease donor work is also happening. And the 3 new dots are in West Bengal, in Madhya Pradesh, and also Rajasthan. They're coming up very well. But yes, we need more and more organ donation, and this whole map has to be dark in color. Next one. Next slide. National liver allocation policy has recently been suggested by the Liver Transplantation Society. We are still based on a hospital-based rota for the allotment of liver. And as Dr. Anil said, with more digitization, this should become disease severity based so that throughout the country, whichever patient has the maximum, the severe disease who needs the liver most, gets it first. If that can be achieved within each state, that'll be fantastic to start with. Next one. So we have suggested a pretty complicated looking, but quite simple severity score. Next slide, which is now published. Next slide, please. And I would love to see, besides the normal clinical data, extra points given to families of organ donors. It'll be very nice if we can give organs to families that have actually donated and give some benefit to them right back. Next slide. Expanding the disease donor pool, we are now taking donors from patients above 65. This is my mother-in-law. She was 75 when we donated her organs, and I'm very happy to say that recently I ran into the person who received a liver, and 10 years on, she is doing very well. She has got married, she's working 9 to 5, and even has a baby. So this is how even elder or senior citizen livers can work. Livers with extra fat, organ dysfunction at procurement, we've gone beyond 12 hours. We are able to use now donors who have hepatitis B, C, HIV with some precautions. And very recently, next slide, we are now, next slide, please. We are now looking at donation after circulatory death. So far, we have been talking about donation after brain death in the country, but we did a lot of hard work and published this paper in 2022. The revised paper is also coming very soon, where we have given the protocols on how to do donation after the heart has stopped. So this is the next thing forward in the country. Next one. So when the heart has stopped, we have to perfuse the organs, and there are two ways of doing it. As one is on the left side, where we perfuse within the body, the in vivo, and the other one on the right side is where we take out the organ, put it on a machine, and put blood through it and see how the organ is working. So these are the two ways forward where we can use organs after the heart has stopped. Next, and possibly the last slide. So we have completed 25 years of liver transplantation. A lot of expertise is there in the country, and living donation we are very good at. But of course, donor safety would remain a concern. We need to expand the disease donor liver transplant by increasing donation after brain death, starting donation after circulatory death, and also developing low-cost indigenous machine perfusion systems for our marginal organs. And most of all, for the common man, we must have a liver transplant program in the public hospitals. And liver transplantation needs to be accessible to everyone, equitable, and accountable. Thank you very much for your patient hearing.
Thank you, sir, for that crisp presentation. And then you kept using, we are getting better and better. And it is so good to see that you're doing older, you're doing obese, you're doing sicker, you're doing acute and chronic. And when you compare with your registry, with 1 year, 5 year, and 10 year, we are also benchmarking with other established players. You did recommend about the national liver allocation policy based on severity scoring, and very new idea about donation after circulatory determination of death. And hopefully under your leadership and with your push along with Noto, Roto, and Soto, we will be able to sort of see that at some point of time. But thank you for that wonderful presentation.
Thank you.
I would now like to call upon Dr. Anant Kumar. Sir is the chairman of Max Kidney Transplant Program, and he's a renowned urologist and a transplant surgeon with extensive experience in kidney transplantation, urology, and robotic surgery, and has been very well known in research and academic field and has contributed enormously. So we would love to hear from you with and please share your experience on renal transplantation. Over to you, Dr. Anand.
Yeah, at the outset, I would like to thank Ficci and Noto for giving me opportunity to speak. And I have been told that this forum is for the general public, so I made it a very simple presentation for the general audience. Next
Absolutely.
slide, please. So what is kidney transplant? In a plain, simple word, it is a replacement of non-functioning kidney with a good functioning kidney from a healthy donor or a cadaveric donor. Next slide. So what to do when your kidney is failed or is failing? Next slide. So you have an option, either remain on dialysis or undergo kidney transplantation. And kidney transplantation is the best option in all parameters. Next slide. So, dialysis is good. Nowadays, when people are living on dialysis more than 10 years, but life is still not normal. You are tied up to a machine. You have to go to the hospital at least 2-3 times in a week. It's expensive. You need vascular access. Next slide. Next slide. And you have to follow a strict schedule, a strict diet, water intake, and still you'll develop some complication which cannot be avoided while you are on dialysis. Next slide. And the quality of life is also not good because you have to be absence of the work. Even if you're traveling, you have to make sure where you are going there is a facility for the dialysis and other things. Next slide. Same way, peritoneal dialysis is good. You don't have to go to the hospital, but you have to do it at home. And you have to do at least 3 to 4 times exchanges. If you have a machine, you can do it at night. You have to maintain a very strict aseptic precaution while doing it. Otherwise, you might develop infection. So all these things do have problem. Next slide. So what is the renal transplant? Renal transplant is the best option. I tell everybody in a simple word why we are living well, because our kidney is working. Once you get another kidney, that will start working and you will also become normal. Next slide. And it has been seen the life expectancy on people who have done transplant is a lot better than those who remain on dialysis. Younger people do a lot better than older people. Next slide. And transplant also decreases cardiovascular related complication which happens while the patient is on dialysis. In dialysis, patient invariably require hospitalization. In transplantation, they do sometimes, but not as frequently as the dialysis patient. Next slide. And quality of life is good because you feel near normal. The only thing you have to maintain a good hygienic condition. You have to take the good hygienic food and clean water. And you have to take immunosuppressive as schedule fixed by the doctors. Maintain a good lifestyle. With that, probably you will be leading a near normal life. Next slide. And kidney transplantation is also cost effective. After 1 year, second year transplant onward, kidney transplant is lot more cheaper than the dialysis. Next slide. And transplantation, the one good thing is your sexual function and fertility is resumed. We have many patients who have fathered or mothered not 1-2 children after the transplantation. Next slide. So now the kidney transplantation, which was the first transplant started in 1954, has also advanced in big way. Like since 1998, at least I have been doing all donor nephrectomy laparoscopically. So the donor stays for 2-3 days in the hospital, get a very small incision, kidney is out. And then it is very cosmetically superior, less pain, less morbidity, less painkiller. And within 2-3 weeks, he's fit to go back to his work and can do anything. And same way, and whether it is a left kidney, right kidney, multiple vessel, single vessel, horseshoe kidney, we have done all kinds of nephrectomy. We do approximately between 250 to 300 transplant every year. and hardly we have refused any donor unless it is contraindicated medically. Nowadays, we also have technology to do kidney transplant robotically. So again, the recipient get a very small incision and the whole procedure is done robotically. So that again, it's less morbid procedure, less painful, less analgesia required, no wound infection, and patient can go home. And it's very good for the obese patient, females and children. Next slide. So who all can undergo kidney donation? So that kidney transplant can only happen if there is donor. If there is no donor, there is no kidney transplant. So for live donation, the kidney, there is another advantage. It's a paired organ. You have 2 kidneys, so you can donate 1 kidney. As per law, that relative can donate either first degree or second degree. Wife becomes related with the marriage. Parents, children, cousin, niece, all can donate. Next slide. Laparoscopic donor nephrectomy is very safe. Complication rate is very low. Wound infection is not there. Hardly anybody needs blood transfusion. Patient is stayed for 3-4 days. Incision is small, pain is less, very cosmetically superior. It is phenol-steel incision lying just above the pubic symphysis. So that we encourage the donor, and if anybody is very scared, we let him meet to the other donors and then the confidence comes back. Next slide. I'll be just showing since it is for general public. Can you just click the first, yeah, just please click it. It is an animation to show what is transplantation. In transplantation, there is one person who is getting kidney and one person who is donating the kidney. So most of the time left kidney is taken out, but we take right kidney also as and when indicated. Kidney has got one artery from where blood comes and it gets filtered out. It excretes all the material which is not required by the body, and blood returns by the vein and it is excreted through the ureter into the urine. So that kidney is removed, artery, vein is cut, ureter is cut, it is kept into, and that it is reconstructed, whatever is required. And then kidney is lifted part of the abdomen, either right side or left side. Renal artery is anastomosed to the artery which is going to the coming out of the leg, and the ureter is put to the bladder so that this get blood supply, secrete the urine which goes to the bladder. Next slide. Next, can you click the next? Yeah, and this is the robotic transplant. Exactly same operation is now done with the robot. Very small incision is given in the phenosteel region, 6 centimeters is dropped, and then the whole operation is done with the help of the robot. So whether it is a left kidney, right kidney, left side, first transplant, second transplant, and it's very good for obese patient because doing kidney transplant in obese patient is very, very difficult, and wound infection is very high. But with the robot, all those problems are not there. And even children, it is very good because they just start eating in the same evening, and they get less pain, less analgesia requirement. And the whole procedure is done exactly as we do the open operation, except that it is abdomen is not cut, kidney is dropped, and robotic arms goes inside, and the whole procedure is done with the help of robot. And the kidney start making urine, and results are not inferior. Rather, in obese patient, I will say results are superior. And many patient, what happens in the same our ICU ward, renal transplant ICU ward, there are patients who have undergone robotic transplant, undergone open operation, and when they eat and meet each other, then they come back and tell, oh, I think I should have also gone robotic transplant. This guy is moving around, doesn't have much pain, and I am still having some pain. Next slide. Next slide, next slide. Next slide. Yeah. And you can see it, you can click it here also. And you can see that in open operation, you get such a big incision. And then it is the pain is not only incision and cutting the muscle, it the retraction also gives the pain. And in the robot, you just cut only 5 to 6 centimeter incision, drop the kidney, and with the help of the robot, you do the whole procedure. Next slide. Next slide. So I will also like to touch that organ donation is a very important aspect, and nowadays it is possible to donate so many organs. So if your liver is not working, heart is not working, lungs are not working, intestine is not working, eyes are not working, you can get it replaced. Your bones, skin, hands, so many things. Face transplant is being uterus. So slowly and slowly, you testis transplants, everything is being planned. Even penile transplant has been done. So a lot of development is happening. So the organ which is not working can be replaced. Next slide. So what we do ourselves will die. What we do for others will remain important. So life is amazing. Pass it on to others. Next slide. And it is not uncommon sight. We see so many accidents happening. So many people are dying in the hospital because of brain hemorrhage, because of the anoxia, suicidal attempts, head injuries. And finally, we don't get consent and the organs are wasted. But if we get consent in this situation, so many people can get life. Next slide. And once the consent is refused, they are cremated or buried. But if we get the consent, we can save at least 6 to 7 lives, 2 eyes, 2 lungs, 1 liver, 2 kidneys, heart, and so many other tissues can be transplanted. Next slide. So we have to make all efforts so that people understand, come forward and donate it. And in India, approximately 500,000 people die because non-availability of organ, whether it is heart, liver, kidney, so many other organs, and they could be significant number could be saved if you have a very good disease donor program. Next slide. I have already covered it, and yeah, next slide, next slide, next slide. And you can see these are the various organs who can be transplanted. Next slide. And we can also get many tissues. Next slide. Like cornea, skin, bone marrow, heart walls, middle layer, tendon. Next slide. So why should we donate? The question comes, many people ask, why should we donate? But once they understand that, yes, everybody should donate, then they come forward it. Is that by doing that, you are saving somebody's life. Person who is really in trouble, can't breathe, can't eat, can't walk, had so many problems. By giving the organ, he start living normal life and become a productive person in the life. And donation is free. You can register free as Dr. Anil has shown, and you can decide what organs or tissue you want to give. And you might never know when you or your loved one might end up into the waiting list. And then you will think that if people are donating the organs, I will get one. You can give people the ability to be mobile. You can give life, even you are not there after death. Next slide. But there are various problems, but those problems can be sorted out. You can see there in the west and south, organ donation rates are higher in comparison to the north and east. And that we should make effort that in the whole country, organ donation should increase. There are various religious myth, professional ignorance, apathy to the cause is the most common cause. And this apathy is amongst the medical people. A lot of people are not even aware. Some medical colleagues, when you talk, some of them even don't know. And some are afraid of participating in fear of being accused. and some don't know what to do. So some people are fear of litigation, poor communication, but all these things can be sorted out by constant communication, various seminars, CME, webinar, lectures, organ donation program, awareness program, and all these things are going to help. Because we have seen when I did first cadaveric transplant in 1988, there was no law, and everybody thought that we are doing some experiment. And now you see at least so many donations are happening. So we have moved, but there is a lot more path to cover. Next slide. So how do we get organ? We get organ from the live donation, especially if there is a paired organ. And it's also nowadays you have heard doctor said that part of the liver can also be donated. And the best part should be that we should get disease donation, whether after the brain death or after the heart cardiac stopping. And that should be the aim. Rather that utopic situation is that everybody should get organs from the cadaveric one, and there is no need to do live donation. But that is a dream, and it will take a long time to go away. Next slide. So there is a two types of situation where organ can be retrieved once the patient is brain dead, because once the patient is brain dead, he cannot survive. And there is a simple test which is approved by the NOTO and Government of India by the rule, and that once those tests says that patient is brain dead, 1, 2, 3, 4 or all organs can be donated. Or in one condition, next slide. Next slide. So, and nobody after the brain death has survived, and these patients are on ventilator. The problem is sometimes it is difficult to explain to the relative. They say that patient is breathing, heart is pumping, ECG is going on, heart activity is there, patient is producing urine, and then we have to convince them this is only a matter of time, 2, 3, 4, 5 days. Nobody has survived. He will also not survive. But this is the window of opportunity. We can prepare, we can organize and give organs to people who need it. And some understand, some don't understand. Probably in future more and more people will understand. Next slide. And donation after cardiac death can only happen if it is the cardiac death happen in the hospital. If somebody heart has stopped at home, it is very difficult. Even if it happens in the heart in the hospital, it the whole team has to very quickly move, talk to the relative, get the consent. It can only possible if they are sensitized and they understand, and then shift once the heart has stopped, confirmed that no resuscitation is possible, ECG is flat for more than 5 minutes, then patient can be shifted to the OT, and immediately organs can be retrieved. Most of the time liver and kidneys are retrieved, and eyes. But if it is done very quickly and patient is put on by some other means, then it is possible to take other organs also. Next slide. Is there any age limit for organ donation? Yes. In live related program, 18 years the age of that person has to understand what he is doing and is mature enough to give the consent. After that, it all depends. That person has to be healthy. He should not have any disease. If he's healthy, he can donate as part of the liver or his one kidney. Next slide. For organ for the cadaveric program, kidneys are usually taken up to the age of 70, 75 years, but we have people who have donated 82 years, 84 years, 92 years also. But then we have to put both the kidney into the one person. Heart, lungs up to 50 years, pancreas, intestine 60, 65 years, cornea, any age after the death, heart walls up to 50 years, bone up to 70 years. Next slide. And as Dr. Anil has shown that we can become a donor, there is a very simple procedure. You can sign a card. Nowadays, it is at the back of the driving license is also available. There is a form. You can go to Noto website and register. You can fill up a card and put it in your pocket. But it is not only signing and becoming the donor. You must inform your family members. Yeah, you must inform your kith and kin and near and dear that you wish to donate your organs, so that everybody understand. And in India, at least, we always take care of the wish of a person when he is dead. Next slide.
So will it be possible to?
Yes, I'm just finishing it.
Sure.
Next slide. And these are the various time limit where the various organ can be harvested. Next slide. I think I can stop it because there is 1-2 slides about the organ awareness. So I can stop it here, and we need to move further to make organ donation possible. More and more organs are donated, so more and more people will be benefited. Thank you.
Thank you, sir, for that very, very simple and very effective presentation to come from a very large volume. And you did mention, covered the journey from 1954 onwards to very technology-driven robotic transplantation, where there are complication rates are lesser. You also did mention, and you answered a question which was there in the chat box, that what would be the age of donation, which also you have very succinctly covered. So I would request the remaining presenters to kindly be crisp, and if you can present and complete your presentation within 5 to 7 minutes. We have Dr. Sundar, who chairs the Department of Heart and Lung Transplant at Apollo. He had been the driving force behind development and successful heart and lung transplant at Apollo, and is coming from one of the leading centers, and has managed very high risk and tremendous innovative approaches. So it is, thank you, Dr. Sundar, for accepting our invitation, and thank you for being part. Over to you.
Thank you. I first of all thank the organizers for inviting me to talk on lung transplant. I'm very mindful of the time, and I shall, try to keep time as much as I possibly can. Next slide, please. Well, the acknowledgements here include data from the Noto website, Transplant Tamil Nadu Transplant Organization website, some medical journals which I've cited. The talk is directed to non-medical audience, and I will not delve into the technicalities of heart and lung transplant. Next slide, please. To give an overview, I'll start off by saying India has come of age as regards heart-lung transplant. I will touch upon who needs heart-lung transplant, emphasize the fact that the donor organs are scarce and there's an increased demand for them, touch upon Noto, Roto, and Soto, talk about situations unique to heart-lung transplant, usability of transplants, and how one increases the donor pool. Next slide, please. Who needs a heart and lung transplant? Basically, anybody who's had all treatment options exhausted, there's no other option for them. You think of a transplant, whether it's a heart, lung, in that case, both a combined heart and lung transplant may be needed. And if you look at the Indian scenarios, patient factors, physician factors, and late presentation, patient often, as a default mode, tend to avoid surgery when offered. And by the time it's too late, and the organ cannot get better, and they end up having to have a transplant. Next slide, please. Indian hearts are different in that heart disease affects them in younger age. It's more diffuse, affecting all branches of the blood vessels to the heart. The blood vessels to the heart are smaller, and there is a higher incidence of premature deaths in Indians. Next slide. How are lungs different from other organs? It's only when it communicates with the environment. The other organs, heart, lung, liver, kidney, I beg your pardon, not the lung, are all inside the body, whereas we breathe the air that the others in the room breathe out. So there is a mix of, what the air breath in the room, and the transplanted lung is directly in communication with that. Now that facilitates and increases the risk of infection after transplant. Next slide. Burden of heart and lung failure in India, the demand is always in excess of the available organs worldwide. This is a worldwide scenario. Data is accumulating in India. Next slide, please. There was this recent article in Lancet 2023 where they say the burden due to heart disease in Indians is much higher than the global average. It's about 282 deaths per 100,000 in India compared to 233 deaths per 100,000 in the world. Next slide. People have discussed this previously. Living donors where liver, kidney can be harvested. Lung theoretically can be, but it's not being done in India. It's done only in a few centers in the world. Next slide. Disease donor is what we're talking about, cadaveric or brain death, and this lists the various organs which can be harvested. Next slide. The various organizations helping at the governmental organizations, NOTO, the director, gave us a good talk on the transplant scenario in India, Roto Soto. We have non-governmental organizations as well, which help in transplant, notably the Mohan Foundation. Next slide. This is the homepage of the NOTO website from which I have taken data. Next slide. The data from 2013 to 22, it's a 10-year period. Next slide. This shows there is a gender disparity. More of donors are males. And if you can see the pie chart, it's less than a quarter are diseased donor, and the great majority are life-related donor, about 35,000 compared to 2,500 diseased donors. Next slide. Over the years, this bar chart shows the number of transplants. Heart and lung virtually cannot be seen. The tall bars that you see refer to liver and kidney. So I'm delving deeper in my next slide. Next slide. Yes, this is the heart and the lung data. You can see annually you've got about around 200 hearts per year and 140 hearts per year of lungs being done. Next slide. The organ utilization rate. Now, this is quite important. Not all donors' heart and lung can be used. Next slide. Now, this is the website of the Transplant Authority of Tamil Nadu, which talks about organ utilization rate. Next slide. Looking at 2018 to 22, one is becoming clear that the heart and lung organs are the least usable organs. Next slide. Now, this is the chart. I would request, this is an animated chart. If you can see listing the percentage of organ use, just click enter once, please. You can see the kidney and the liver, as much as 85 to 95% organ usage is there, which means out of 10 donors, as much as 8 to 9 organs are salvageable as far as liver and kidney are concerned. Enter again, please. The heart scenario you can see is less than half, 50% are usable. Next scenario. In the lungs, the usability is even lower, somewhere close to 20 to 35%. Next slide. Why is the usability low in the lungs? The common brain dead donor is usually an unfortunate victim of a road traffic accident, commonly a head-on collision, and the steering injury, not surprisingly, injures the chest. People who have lots of alcohol in an inebriated condition end up vomiting and swallow their own vomit. And if they are brain dead after an accident, their lungs are not usable. Furthermore, there are many smokers, TB is endemic, and there is pre-existing lung disease, which makes the lung usability index or ratio to be less than 20 to 30%. Next slide. So what makes heart and lung patients more critical? Unlike kidney failure patients, as spoken to elegantly by our previous speaker, they can be managed by dialysis and they can be supported for many years until an organ is available. Although heart and lung patients, when they are critical, can be supported, it is only temporary, maybe a few weeks and sometimes few months, and now that is an expensive affair as well. Next slide. So what are the challenges for patients awaiting heart and lung organs? Next slide. All this boils down to donor pool. In heart and lung, we know it's only cadaveric organ transplant possible. The donor pool is limited. And I just spoke how, unlike kidney failure patients, heart and lung patients, when they are critical, cannot be maintained for long. And again, we discussed the organ utilization is pretty low. Next slide. So how does one increase the donor pool? One was by an extended donor organ criteria. There are some standard criteria which defines a good organ, which we can use for all patients. However, life is not black and white. There are shades of gray in between. So extended donor criteria has been used by the heart and lung transplant community in terms of patients who are critically ill in the ICU, on an ECMO or an artificial heart machine, on life support, where we do not know if the person is going to survive the following morning. And we do not know when the next organ is going to be available. We don't have the luxury of time to wait for a good organ. In such times, having explained to the relatives, marginal donors have also been used. DCD, death after cardiac donation, has been spoken and alluded to by a lot of our previous speakers. Organ care systems, wherein the organ can be harvested and put in a machine and perfused and given oxygen so that long distance travel is allowed, and also marginal donors can be checked after treating the organ, and if they get better, could well be used. And the last would be an opt-out versus opt-in policy. Next slide, please. The organ donation policy globally is either an opt-in or an opt-out policy. In India, we follow the opt-in policy where the patient expresses a wish to be a donor, which means there is an express consent available. On the other hand, the opt-out policy is where all patients or all citizens in a country are assumed to be donors unless they specifically opt out. So here, unlike express consent, presumed consent plays into play. Now, logic would say that if we all followed an opt-out policy, the organ donation rate would increase. But we've had studies which show that there is no significant difference between opt-in and opt-out policy. Next slide, please. Awareness program, it all boils down to that. Public awareness may be the best way forward to increase organ donation. And I must have to talk about the Hitendran effect, which happened in 2008, which was a pivotal point in organ disease donor in India. Hitendran was the unfortunate teenage son of a doctor couple who was a victim of a road traffic accident and was brain dead, and the doctor couple came forward to donate all his organs. Now that involved and stimulated a media frenzy, and there was so much of exposure and awareness. From 2008 onwards, there was an exponential increase in the disease donation in Tamil Nadu, and it was followed suit by all other states in India. And awareness programs are being conducted by NOTO, ROTO, SOTO, and NGOs like Mohan Foundation on a regular basis. And Organ Donation Day is observed on the 3rd of August every year in India. Thank you for your attention.
Dr. Sen, you're on mute.
Thank you, sir, for that emphatic presentation, and thank you for keeping time. And you did mention about the least usable organ, but you're doing some fantastic work, and your idea about increasing donor pool and all your suggestions, opt-out, opt-in, and presumed consents are very well taken. And please stay on. We would like to discuss that more if the time permits. I'll quickly go on to Dr. Mohit Sharma, who is a professor and head of plastic and reconstructive and have done hand transplant in the country, and would request him to restrict himself to 5 minutes. I know I'm not doing justice, but we have somehow overshot the time. Over to you, Dr. Mohit.
Thank you, Dr. Sanjeev. Can you start moving the slides, please? Yeah. So our team first time started the hand transplantation procedure in our country in 2015, looking at the great need of people who have lost their hands and who want to live their life. It's not a life-saving procedure, but it is a life-enhancing procedure. And after that, the cascade effect happened, and many centers have started doing it. We have trained the surgeons to perform this transplantation and conducted a lot of workshops. So now India has become a leader in the field of this transplantation service. Could you go to next slide? Yeah, so go to next slide, please. Next. Yeah, so these are the institutions who have done, and at Amrita Institute, we have done hand transplantation in 17 patients, total of 32 hand transplants we have done, which is highest for any center in the world. Next, please. Next. So this is the worldwide data. There is not many transplants have happened, around 175 or something is the total transplantation number. The total number of transplant patients done in US is the highest, that is 37, and India has done in, by the time I am speaking, it is around 35 patients. Next, please. Next. Yeah, so, and our country has done the highest number of bilateral hand transplantation in the world, which is much more ethical. There are issues with that if somebody has a single hand, he can do most of the work. So why to subject him to immunosuppression? So we have tried to be extremely ethical and conscientious in our approach. And that's why our double hand transplant patient numbers are very high. Next. This is around the approximate number of the transplantation in the world, and India has already become leader in the field, and which many people say is still not the standard of care, because very good prosthetics are being developed. But still, when we think about the double hand transplantation in persons who have lost both the limbs, it is still one of the best things that can be done to a patient as compared to even the best prosthetic hand. Next. So this is approximately the cost. Our cost of hand transplantation in India for government hospitals, it is totally free, and for private hospitals, it comes around 25 to 30 lakhs for a double hand transplantation, which becomes an incredibly complex 4-team procedure. And the cost of immunosuppression is similar to that of a kidney transplant patient. Next. Next, please. There are a lot of things we have to press many more times. So around 25,000 amputees are coming into the existence every year because of a lot of burns and road traffic accidents. And there is a huge need to promote this transplantation. Next. This is the number of patients that we have done. Next, please. I think these are our patients, and you can quickly move through it. You can just keep on moving ahead. So these are our patients. This is the kind of great function that can be achieved. Is this video running? So they can return back to their normal activities, and they achieve almost near normal function for the distal hand transplant, and their lives become totally normal. Next, please. Move on. You can move to the next slide. Yeah. Next, please. So this was a girl who lost both the hands in a road traffic accident, and now 7 years down the line, she's able to do everything. She can write for more than 3 hours, and now she's doing her MBA from IIM Kolkata. Keep on moving, please. And transplanted patient is able to live a near normal life and is able to get on with his daily activities. So definitely there is a huge need for this type of procedure, but this is not being fulfilled right now, because many of the centers who are promoting the solid organ transplantation are not tuned to asking about the hand donation. So it is my earnest request to all the senior doctors here and all the hospitals and the coordinators, that when we are asking for the solid organ donation, if we can ask for the hand donation also, so these kind of patients can be benefited a lot. So what we do, that whenever, just go to the back slide. So when we ask for the hand, the main concern of the patient is mutilation of the body. And what we do, we provide the donor with the prosthetic hand so that they don't look mutilated. And then we have also gone about the felicitation of the donor families, and really making them in their great donation into light. Next, please. And by public felicitations, we are trying to generate awareness about the great service they have done to the humanity. And this is the only way in which it can be, we can just go about having more and more donations. So we understand that transplant coordinator education is very important, but the most important thing is the keen involvement of neurosurgeons, critical care specialists, and anesthetists when they are declaring a patient brain dead. At that time, if they can ask for hand donation also, a lot of people who are waiting in despair, their lives can be rehabilitated and can be changed for the good. Next, please. So that I have talked about the motivation and education of transplant coordinators. And next. So we can encourage more transplant procurement managers in the government hospital, employ more trained coordinators, and the primary treating physician, if he can ask about the hand donation also along with the solid organs, it could go a long way in promoting this this transplantation and change the lives of a lot of patients. Next, please. Next, please. Next, please. So this is how we felicitate, and this is our patient, our first transplant patient, who, and on his 15th day of recovery, the first thing when we told him to write, he thanked the donor who gave him the hands, and that's what he wrote at the second week of his transplantation. Thank you very much. Just next, please. Thank you very much.
Thank you, Dr. Mohit. That was extremely touching. The first note which they write is thanking the donor. And thank you so much for taking out time and sharing this phenomenal success. Everybody is talking about awareness, transplant coordinator, involvement, and clinical team engagement. And who better than Mohan Foundation can play that role, because they have done a crucial role in advocacy on organ donation, creating awareness and providing support. And they have been very, very instrumental in training healthcare professionals, grieving counseling, and engaging with the community. So over to you, Madam Pallavi. And thank you so much for doing such fantastic work over the years and the great contribution to the nation.
Thank you, Dr. Singh. Thank you, Ficci, for having me here. If you can just move to the next slide. So really, why is it that we should be talking about organ donation? And very often, when I ask this question in a room full of people, the answer that comes out is to save lives. You know, there is a huge demand and supply gap, and we need to save lives. Just go on. Next slide. Next slide. Look at what this family had to say. This is one of the families that I've had the privilege of working with. In fact, very special family. In fact, any family that can say yes to organ donation, you know, come out of their grief and loss and look at the interest of others is a special family. But this young boy on the left is Bhupendra. And later on, when I went to meet the parents, this is what the father said. He said, मैं सोचता रहता हूँ कि अगर मैं आपसे ना मिला होता, भूपेंद्र तो मेरे हाथ से चले जाता और मैं organ donation भी ना कर पाता, मैं दूसरों की जिंदगियां भी ना बचा पाता. Just imagine the largeness of thinking in this whole thought. And I think we need to talk about organ donation because it is every individual's right. It is every family's right to be given this option, because organ donation is a beautiful way to find some light amidst the darkness of death and loss. Next. And yes, of course, if the families say yes, we are saving lives. I'm not going to talk about the statistics, but it's suffice to say that every organ that is wasted, that is buried, that is burnt is a life lost. It is an opportunity to save a life lost. Next. And I think Dr. Sundar said our country relies mostly on living donation. 95% of our transplants are living donor transplants, whereas any healthy way of conducting transplants should be from deceased donors. In any case, it is only kidneys and livers that can be taken out of living donors. For most other organs, like Dr. Sundar said, for lungs and hearts, we need deceased donors. So we have to, as a country, as citizens of this country, have to start thinking about organ donation. Next. Dr. Anand Kumar has covered this. So there is a living donor that can give one kidney or a portion of the liver. And what we are interested in today, a deceased donor has to be brain dead. Brain dead is also something that Dr. Anand Kumar covered. Please go forward. But it is important for the layperson to understand that brain death is death. It is not to be confused with coma. The person is not alive. In coma, the person is in a deep state of unconsciousness, but the person is very much alive. He may or may not come out of coma. He may move into a long-term vegetative state. But till such time an individual is medically and legally alive, nobody is talking to them about organ donation. Organ donation conversation only begins when death has been declared. And in this case, it's called brain death. Next. It's a serious matter to declare somebody brain dead, so it is done in a very serious manner. Hospitals have to get a license to declare brain dead. A team of 4 doctors conducts a series of tests that have been laid down in the law. Tests are done twice. In most countries across the world, they are only done once, but in our country, it's done twice. Next. And after a lot of testing, it has been one of the most common causes of brain death is road traffic accidents. So unfortunately, a lot of our donors are young people, and that is why they need to put on a helmet and be careful. Next. So from the first speaker, like I said, not to be confused with coma, brain death is death. It's a different form of death, and organ donation is only being spoken about after death. Next. From the first speaker onwards, from Dr. Anil to Dr. Avnish Seth, everybody kept talking about India's organ donation rate per million population. What does it really mean for you people? It means that in every 10 lakh Indians, not even one Indian goes on to become an organ donor. That is how low our organ donation rates are. There is plenty of potential for it to increase. We are a huge population. Sadly, a lot of accident deaths. If we all collectively create awareness around this area, we can very sufficiently bridge the demand and supply gap. Next. Next. So very, very quickly, there is natural death, as you and I understand death, where the heart stops beating. In that case, unless it's in a controlled situation, we cannot be solid organ donors. Very often we get calls from people at home that so-and-so have died in the house and we would like to be organ donors. So solid organ donors that save lives, like heart, lungs, kidneys, liver, pancreas, these can only, as of now, in the current scenario, happen in the case of brain death or some very controlled circulatory death. But in natural death, you can be what is called tissue donor. And if you can go ahead, next slide. Just about everyone who dies can be an eye donor. And in 2024, if people say no to eye donation, I find it a little difficult to stomach. I know organ donation is a bigger ask, but just about everybody can be an eye donor. And I want to quickly talk to you about eye donation. You remove the cornea. Cornea is a very thin, transparent covering on the black portion of the eye. When somebody dies, the idea is that the cornea should not get dried. So you close that person's eyes, put some moist cotton on the eye, put up the fan, if possible, put the AC on, otherwise it's not a problem. Contact your nearest eye bank, contact your nearest hospital, contact any of the NGOs. Eye donation, if you want, will happen. Organ donation, perhaps, even if you want it, sometimes our infrastructure may not support it. But please think about eye donation. My dad, we donated his eyes. The team came, retrieved his corneas, left in 18 minutes. It's just such a simple surgery. There's no disfiguration. Please, next slide. Just some myths. I just want you to go ahead. I don't want to cover the myths. I want to come down to some actionable points. Next. No religion forbids organs. There is no mutilation to the body. It's done like a surgical procedure. Next. All right. So what can you do as an individual, as a general public? Become informed. Just be knowledgeable. If the doctor is trying to tell you and explain to you something, you should at least have the semblance of intelligence to absorb that information. So read about brain death, understand how it is different from organ donation. Then you can pledge. We've been talking about pledging right from the beginning. Carry your organ donor card proudly, and most importantly, convey it to your family members. In our country, pledging is not a legal activity. It is only an expression of your willingness to donate. In our country, family has the final right to decide whether your organs will be donated or not after you have died. So please speak to your family, have that conversation, and encourage others. Next. Then you can become a volunteer. You can volunteer your time and volunteer your skills. Next, I'll tell you how. All of you here, many of you are working in companies and schools. We will come to the session and encourage people to pledge for organ donation. Next. And to end, the foundation has an online ambassador program. Here, you can actually go through a 4-hour learn at your pace online certificate course on organ donation, after which you will be certified to conduct awareness in your resident welfare associations, on your offices, or in any other places, because we would have trained you with the right knowledge, legal, medical, organ donation related, to be able to conduct such kind of activities. Next. Thank you so much. Just some people, families who reminisce about their loved ones and know that even though they lost some loved one, they look back at the death with happiness and pride. And it is something each one of us have to begin to look at and think about and discuss. Thank you so much, Dr. Singh.
Thank you, Madam Pallavi. Your passion is very, very contagious. And thank you for bringing all the relevant points. It is a very serious matter. And you stressed upon informed donor, and very nicely that you have introduced online ambassador program. But thank you for what you do on a day-to-day basis to the country and the citizen.
Thank you so much.
Very, very good. You also touched upon Bhupendra, and you mentioned about his experience. So we also have a transplant recipient today. That's Madam Tuhina Banerjee. And I would request her to kindly share her experience. And thank you, Madam, for joining us and accepting our invitation and sharing your...
Sir, for inviting me. Being a patient, I can only express my gratitude to my doctors, and to just tell you that I was very fortunate and lucky that I got a cadaver donor. Actually, I was diagnosed with chronic liver disease in 2019 by Dr. N.M. Tiku of Apollo Indraprasth. So after that, he just told me at that time only that I can control my disease with some medications and restrictions for some time, but I have to think about liver transplant at some point. So after that, my problems aggravated, like portal hypertension and ascites and tremendous pain in my stomach and low platelets, hemoglobin and what all. Then I registered myself in 2023 and Dr. Nirav Goyal, the head of the Department of Liver Transplant in Apollo Hospital, he just explained me the procedure and the risk associated with this disease. And he and his panel of doctors, his team, they just encouraged me to go through the process as early as possible to avoid more complexities and infections, so that I can just walk in the OT on the day of surgery and have the process without further complicating the thing. So I was operated on 21st April 2024, just 3.5 months before. And now I'm speaking to you all. I'm getting well, though it's a slow process with many restrictions and medications, but now I'm fine. Actually, I have just lost hope during my stay in the ICU. And when I knew that my operation went well, just a thought came in my mind that today I'm alive because some person and his family thought about the mission which you all are working for. Because of that person, I am alive today. And from the bottom of my heart, I thank that deceased person and I prayed for him, for his soul and for his bereaved family. After that, in the ICU itself, I thought if I live for 1 year healthily, then definitely I am going to register myself, because if I can contribute a little, because I have got this life for some person of that mentality, so I should go for this mission, and I will definitely register myself if God enables me for that after my death. And even I will encourage my family members and my friends to do that, so that I can also bring smile, I can also give life to somebody. Because I know, because I have gone through lot of problems, tensions. So I know, because I have personally felt that, and not only me, my whole family has gone through that. So I will definitely do that. I will definitely encourage. Even my son is also ready for that. So thanks to all the doctors, to all the panelists who have invited me. And today I also knew many things about this thing. Thank you, sir, for everything.
Thank you, Madam Banerjee, for being a fantastic champion and expressing your gratefulness and gratitude to the donor who's there. And thank you for also pledging becoming a donor. And not only you said that you would also encourage your family members. And we
definitely, sir.
All of us pray for your very, very speedy recovery. And
thank you, sir.
You're becoming an advocate for donation.
Thank you, sir.
So since we are running out of time, and I would really like to thank all the delegates who are there within the call. I don't know, Shilpaji, is it possible to take those questions, or we'll go ahead with Lieutenant General Puri?
Just a couple of questions in case we can take.
Right. So I am not sure there is there is this, if Dr. Anand is there or Dr. Avnish. Basically, one of the questions was that is there an age of donation? And I think it was covered during the talk, but there had been a couple of questions on what would be appropriate age for donation. Dr. Avnish, Dr. Anant, or Dr. Sundar, anybody who would like to take this?
Yes. I could perhaps
please
comment on the age from the heart and lung transplant point of view. As I discussed, age up to 54 and 55, we consider them as a good organ. But obviously, as the age increases, they come under the marginal category. Nonetheless, they have been used with good results. The oldest donor I have used is a 68-year-old for a lung and a 64 for a heart.
Right, since you're there online, there was another question about Dehedan. Is it possible that they can donate their body other than the organs which we talked about today? Pallavi, if you can also chip in. Sir, Dr. Sundar, please.
Yes, I mean, the donation of the body per se, I think is commonly done where some people, express a wish that their bodies are donated to the medical college hospitals for anatomical dissections and for furthering of knowledge. As regards the actual donation of body, probably I'm not entirely sure about that, and Ms. Pallavi Kumar could possibly answer if she knows.
Pallavi, you're still there? A very quick question. Yeah, Dr. Avnish, very quick question about everybody is talking about disease, the donor after circulatory determination of death.
Yeah.
So is there a movement towards that? One of the questions are, is there a movement towards moving from the liver, live donation, disease donation towards donor after circulatory determination of death?
So there is a lot of movement, and we have lagged behind as a country. Just to give you an example, worldwide, we did 40,000 organ transplants last year. Out of that, 30,000 are after brain death, and organ donations, 40,000, out of which 30,000 are after brain death and 10,000 are after circulatory death. So worldwide, 1/4 of all donations are happening after, circulatory death. So we've had a few DCD donations in our country. We have done, because kidney is quite forgiving, so one can take the kidneys with a rapid retrieval. So PGI Chandigarh and in Ahmedabad and recently in Maharashtra and one in ILBS, we've retrieved the kidneys. What we are trying to now develop protocols is to develop a system where we move beyond the kidneys. So we should be able to take the liver, we should be able to take the lung. DCD lung transplant results are much better than lung transplants after brain death. So definitely this is the way forward, and 9 societies in the country we have got together and we published the guidelines, and I'm sure we will see more and more of this very soon.
Fantastic. So that would be a huge contribution. And why do we have to sort of miss when we are doing less and not meeting the requirement?
Yeah. Just to continue, one quick comment in that. Most of the DCD donations in the world happen when we withdraw life support treatment. So till now in our country, we've not been doing that. But the Supreme Court ruling came in 2023, wherein now it has been very well described how a hospital can withdraw life support. So whenever we can establish futility of care, that this patient is not going to live, there is no point in occupying ventilators and trying to continue treatment. So a board of doctors can get together. There's a primary board and a secondary board, and then we can declare futility and you can actually stop the ventilator. So when we stop the ventilator, in a few minutes or maximum 90 to 120 minutes, the heart stops. The BP comes down and the heart stops. So 5 minutes is a no-touch period where we do not intervene in case the heart restarts. But if the heart doesn't start in 5 minutes, after withdrawing support, we declare that person dead and then very quickly move to the protocols for retrieving the organs. So this new Supreme Court ruling is the one which has spurred now the entire thought process that we should also be doing this.
Thank you so much, sir. That was very insightful. Last question to Dr. Anand. Can I donate organ if I have a serious illness? I think you have answered during your talk, but
yes,
if you can re-emphasize.
We have to see what serious illness you have and which organ it is affecting. So that if it is affecting, suppose you are dying and your kidneys are not good, but if your liver is good, then you can donate the liver. If your heart is good, you can donate that. Suppose you are dying of the heart failure and your heart is bad, but your kidneys are okay, you can donate the kidney. But suppose you have a systemic infection, then probably you cannot donate the kidney, because any organ, because that infection can be transmitted. So if you have a cancer, brain cancer localized to the brain, person can donate. But if any other cancer which can spread any organ, then we don't take it. Anybody who's got severe sepsis, we don't advocate donation. But localized organ, somebody's liver is bad but kidneys are okay, can donate the kidney. So that way we have to see each and individual patient and decide what is good and which organ can be. If nothing is possible, at least eyes can be donated. So body can be used for one or other purpose.
Perfect, sir. Thank you so much. It had been extremely insightful and very, very engaging and enriching listening to all of you, I would really like to thank your expertise and your enormous contribution in the field of organ donation. At this point of time, I would like to call upon a very senior Dr. Bipin Puri, who has an extensive experience in healthcare management, and you hear his voice and you'll know that he comes from defense, and he has been the Director General of Armed Forces Medical Services, and has been responsible for laying down good foundation of hospital management in Indian Armed Forces and various other institutions. And he's presently the Director of Medical Services at Polo. And I'd like to call upon Sir for your closing remarks and for your comments.
Thank you, Dr. Sanjeev, for your kind words. As all of us know, today is 13th of August, and it's an organ donation day. And I was very pleased to see that this year the theme was "Be the reason for someone's smile today." That was really the theme, and I want to begin with by thanking Ficci for taking up such a very contemporary topic for spreading awareness in a very rapidly changing world where the chasm of demand and supply of organs is, increasing exponentially. And I sincerely believe that that organ transplant is a story of renewal where the gift of life is passed from one person to another, bridging hearts and souls across time. So I think having chosen this topic, we've heard the masters in each of the different organs talking about the specifics in their own vertical. It has been a pleasure to hear all of you for doing whatever you are and the expertise that you bring to the table. But I want to talk about two things. Maybe at the cost of being repetitive. But I think it's important at the end game that we must understand that that's the way forward that we require to. One is, though we have increased our incidence of live-related transplants, our deceased donor scores continue to be low, and that's really, really the cause of worry if you compare yourselves with other countries. And therefore, when you look at what are the causes of this low numbers, I think I must repeat these issues: cultural and religious, lack of awareness and education, consent, and family decision. Because you might give your consent for taking away your organs, but after you die, it is your family who has to take the next of kin who have to take a decision. So unless until I think everybody's involved in the decision making, I think that's very important. Social equality, especially in the minority group, there are a lot of minority groups who say absolute no. Fear and grief affecting family consent, very emotional times, and that's where the transplant coordinators come into action. Legal and ethical issues, even now in the complex framework, sometimes result in ethical debates and they impact the public perception. And I sincerely believe that there is a need for us to do a brainstorming, try and analyze what are the gaps in this and try and put this, correct these aberrations. And I think that's really, really a very important thing to take it forwards. I have one more point to make about technique and technology. What has been described by the masters has actually been a sum of some amazing things which have happened in the world and across the globe, including our country. And that's why we have driven the transplant program to where it is today. So a couple of things besides what has already been said: normothermic machine perfusion, preserving body temperature, allowing extended viability, leading to better transplant outcomes is one. Two is 3D printing, creating anatomical models for surgical planning, and which hold future potential for bioprinting patient-specific organs and reducing the risk of rejection is another area where a lot of work is going on. it has already been talked about that AI in organ matching, that swap that we were talking about. So AI in organ matching for accuracy and speed of matching donors and recipients, optimizing allocation process for better transplant outcomes, xenotransplantation of genetically modified pigs. We know that a beginning has been made. We've heard of some small success stories, but I'm sure in time to come, this should also become a reality. And lastly is telemedicine. Telemedicine with remote monitoring with wearable devices for early detection of complications and improving patient outcomes once a patient is discharged from hospital, and you're keeping a track of your patients. So I think what Dr. Avnish and the others spoke about, circulatory death and brainstem death. Now, these are very, very important. These are huge advances in technology, in our understanding and maintenance of these organs, even after a circulatory death, which requires to be taken forward. And I sincerely believe these are amazing, incredible advancements as far as the transplant program is concerned. We at Apollo, Indraprastha Apollo Hospital, started our transplant program in 1998. And to date, we have done more than nearly 8,000 kidneys and about 3,000 livers. So that's the scores that and the program has gone off quite well. The point which I wanted to make here was that live related has predominated, and cadaveric transplant is only in 2 digits. So that's the gap that we have between live and deceased donor. So I want now to conclude that as we continue to perform, reform, and transform the transplant landscape in our country, organ transplant is a very delicate and a future. It transforms grief into hope and loss into life, showing that in our most vulnerable moments, we can find the strength to give the greatest gift of a second chance. So friends, ladies and gentlemen, Ficci, thank you very much for giving me this opportunity for coming in. Thank you, Dr. Sanjeev.
Thank you, Lieutenant General Puri, sir, for fantastically wrapping up with all the challenges and also bringing up innovation. And you did mention about the theme, be the reason for someone's smile. And that is, I think, very, very powerful. I would like to now call upon Shilpa ji for recognizing all the masters and honoring their contribution and to offer the vote of thanks. Over to you.
Thank you, sir. Thank you so much. And big thank you to all the esteemed panelists and specialists over here. This webinar was indeed an eye-opener for many of us who joined. I hope it has inspired all of us here to not only consider organ donation for ourselves, but also encourage our families and friends to adopt this practice, which provides us with the power to save countless lives. At Ficci, we would like to continue our efforts towards organ donation by setting up a working group under our Ficci Swasth Bharat Task Force, which is a public health task force, along with NOTO, AIMS Organ Bank, and other organizations. And we would work towards policy recommendations and awareness generation, as mentioned by Dr. Mahajan earlier. So with this, we would like to close the webinar. A huge thank you and applause to all the panelists here for joining us and sharing your knowledge, insights, and experiences. Also, a special thank you to Dr. Anil Kumar, who had joined with us. And my heartfelt gratitude to the transplant patients and others who have shared those journeys and experiences with us today. And last but not the least, a big thank you to all the audience for joining us and hearing us patiently. We hope we all are taking this message home today. Be an organ donor and bring life and happiness to someone's life. Thank you so much from Ficci. Thank you.
Thank you.
Thank you. Bye-bye.